Hey everyone, and welcome to this Masterclass Explainer. I'm stepping in today as your head of Pediatric Critical Care. Look, as an expert in both Pediatric Basic Life Support and PALS, I really want to talk to you about the most critical moments in any medical emergency. I'm talking about those terrifying seconds where a child's life is quite literally in your hands. Now, when a pediatric patient codes, the panic in the room is just palpable. But, as we all know, panic doesn't save lives, right? Precise practice protocols do. So let's dive right into the exact steps we need to take to maximize survival chances for our absolute most vulnerable patients.
Here is our roadmap for today's explainer. We're going to cover the crucial first seconds, the single rescuer protocol, the two rescuer advantage, infant versus child techniques, exactly why rescue breaths matter, and finally, the soul in arrest. Let's get right to it.
Section 1. The crucial first seconds. When you come across an unresponsive child, time is your absolute biggest enemy. Every single second lost equals potential irreversible damage to the heart and the brain. Your clinical precision in this immediate assessment phase pretty much dictates the success of the entire resuscitation effort. So first things first, always ensure the scene is safe. Move the child out of traffic or away from standing water. Next, check responsiveness. And here's a key difference. For a child, you're going to tap hard on their shoulder and shout their name. But for an infant, you tap the soles of their feet or give a little flick to their back. If you get no response, you need to check for breathing and a pulse simultaneously. And listen to me closely on this one. You are looking for rhythmic chest rise. Agonal breathing, that occasional ineffective gasping, absolutely does not count as breathing. You've got to make your pulse and breathing assessment in at least 5 seconds, but absolutely no more than 10 seconds.
Now, where you check that pulse is vital, and it actually changes based on the patient's anatomy. For an infant, which we classify as a baby under 1 year of age, you want to check the brachial pulse. That's located right on the inside of the upper arm, between the shoulder and the elbow. But for a child, so anywhere from 1 year up to puberty, you should be checking either the carotid pulse in the neck or the femoral pulse down in the groin area.
60. This right here is the magic number in pediatric BLS. If you feel a pulse, but it's dragging at less than 60 beats per minute, and the child is showing signs of poor perfusion, meaning they look pale, mottled, or cyanotic, you treat that exactly as if they have no pulse at all. Do not wait for the heart to stop completely. A heart rate under 60 in a compromised child is an absolute, non-negotiable indication to initiate CPR immediately. Section 2. Single rescuer CPR protocol.
So often, especially if you're outside of the hospital, you might just be the only rescuer on the seat. And this brings up a genuinely terrifying question. What if you are completely alone and you don't even have a cell phone to call emergency services? Do you stay and do CPR, or do you literally leave the child to go run for help? It's a horrible dilemma to be in, but thankfully the protocols give us a very clear answer based on one specific factor.
And that crucial factor is whether the arrest was witnessed or unwitnessed. If you actually saw the child suddenly collapse, a witnessed arrest, you must leave the child immediately to activate the emergency response system and grab an AED. We do this because the heart likely just stopped right then and there. An immediate defibrillation is their absolute best chance. But say you walk into a room and find the child already unresponsive. That's an unwitnessed arrest. You have no idea how long they've been down. They are likely severely oxygen deprived at this point. In this scenario, you must perform 2 minutes of CPR first to get oxygen circulating back to the brain, and only then do you quickly leave to find help.
When you're operating as that single rescuer, your compression to ventilation ratio is 30:2. That means you are delivering 30 high-quality chest compressions, immediately followed by 2 rescue breaths. And you just continue this cycle relentlessly until help arrives or the patient responds.
Section 3. The two rescuer advantage. Of course, working in critical care, we rarely have to work alone, and thank goodness for that, right? When a second rescuer arrives who actually knows CPR, the entire dynamic of the resuscitation shifts. We move from that 30:2 single rescuer ratio right to a 15:2 ratio. We literally cut the compressions in half before giving breaths. Why? Because kids need oxygen. By shifting to 15:2, we are essentially giving the child twice as many rescue breaths over the exact same amount of time. It's a hugely vital physiological adjustment for pediatric patients. With 2 people on the scene, resuscitation becomes this highly choreographed dance. One rescuer takes the chest and manages the compressions, while a second rescuer positions themselves up at the head to manage the airway and deliver those rescue breaths. But look, chest compressions are exhausting, and as you start to get tired, the quality of your compressions is going to drop.
Because of that, you absolutely must swap roles every 2 minutes. When you swap, use a crossover technique. That just means the person at the chest slides up to the head and the person at the head slides down to the chest, ensuring that the interruption in compressions is kept to the absolute bare minimum.
Section 4. Infant versus child techniques.
So, our physical approach has to adapt here because anatomy dictates exactly how we perform CPR. For an infant under 1 year, if you're flying solo, you use a 2-finger technique just below the nipple line. But if there are 2 of you, you switch to the 2-thumb encircling hands technique, actually wrapping your fingers all the way around the baby's back for support. For a child over 1 year, well, depending on their size, you can use 1 or 2 hands on the lower half of the breastbone, pretty much just like an adult. But notice this, the depth requirement is exactly the same for both. You must compress at least 1/3 of the anterior-posterior diameter of the chest. You really have to push hard to squeeze that heart between the sternum and the spine.
And regardless of whether you're working on a tiny baby or a teenager, the speed is universal, 100 to 120 compressions per minute. You need to be loud with your counting, out there, keeping that steady, driving rhythm. Push hard, push fast, and make sure you allow for full chest recoil after every single push so that the heart can actually refill with blood.
Section 5. Why rescue breaths matter.
This brings us to a topic I get asked about all the time as a critical care physician, compression-only CPR, and why rescue breaths matter so much in pediatrics. You've probably seen all those public health campaigns for hands-only or compression-only CPR. And hey, that is fantastic for adults who suddenly collapse from a primary cardiac event like a heart attack, where their blood is already fully oxygenated. But pediatric arrests, they are fundamentally different. Children almost always arrest secondary to a respiratory issue, things like choking, drowning, or a severe asthma attack. So by the time their heart actually stops, they are already profoundly hypoxic. They have burned through absolutely all of their oxygen. Because of this, compression-only CPR is definitely not the pediatric standard. Kids desperately need oxygen, and that is exactly why we prioritize that 15:2 ratio when we have the manpower. It forces us to ventilate that hypoxic child more frequently.
Section 6. The soul in arrest. As we wrap up this clinical overview, I think it's important to remember that, we can talk about algorithms and drug dosages and compression ratios all day long, but we must never lose sight of the profound human reality of what we're actually doing. We are fighting for a life. I want to leave you with this really moving stanza from a poem published in Indian Pediatrics, written from the imagined perspective of a patient receiving CPR. It goes, "My Lord, if I go to heaven, let it be. But tell my family they tried their best, to the best of their ability and availability, wisely, confidently, and passionately." As medical professionals, or frankly even as bystanders, we obviously can't guarantee the outcome. But by mastering these protocols, by knowing exactly what to do when that child's heart stops, you ensure that you are trying your absolute best, wisely and confidently. Thank you so much for taking the time to learn these life-saving skills with me today. I just have one final thought to leave you with. If you walked outside right now and a child collapsed right in front of you, are you truly ready to act?